COVID-19 remain asymptomatic in some and proves to be fatal in others? That's a huge, question which needs to be answered. Yes, we know about the risk factors, respiratory disease, heart disease, diabetes, immunosuppression, and all that. But if you look at the data, it doesn't necessarily marry up those risk factors in terms of fatalities, particularly. And it may be possible that specific strains of coronavirus are more lethal than the others. What's the influence of blood group type, particularly the ABO blood group typing, on the risk of a poor prognosis and fatality with COVID? Genetic factors. So there are quite a few issues. And what we also need to appreciate is that whilst COVID-19 is being treated as a respiratory illness, primarily life-threatening pneumonia, but there is growing evidence that the CoV-2 virus ultimately targets the vascular system. Now, some of you may realize that ACE2 receptors are the primary targets for CoV-2. And the ACE2 receptors basically downregulate the renin-angiotensin system. If I can ask the moderators to please check, I think quite a few mics are still on. So if you could please check and mute everybody else.
We have checked it. There are no microphones that are turned on. It's just, I think there's another issue there that we're trying to sort out, but there are no mics which are open.
Thank you. So one of the huge challenges is the attack of the CoV-2 virus on the vascular system. So as I was saying, the CoV-2 virus attaches to the ACE2 receptors, which basically downregulate the renin-angiotensin system. And these receptors are not only present in the lungs, but also in the blood vessels, GIT, kidneys, etc., etc. And that might explain some of the observations we've had in patients who've died from COVID or who've had, critical illness like strokes, heart attacks, kidney damage, end organ failure, disseminated intravascular coagulation, and a lot of things you hear about the benefits of vitamin D are also related to the fact that vitamin D also downregulates the renin-angiotensin system. So when the CoV-2 virus attacks the attaches to the ACE2 receptors, the downregulation balance is disturbed, which allows the renin-angiotensin system to work unchecked, which may be responsible for strokes. So the bottom line is it primarily a respiratory illness, or is it just that the lungs provide a route of entry for the virus, and then many of the manifestations of COVID-19 are related to the vascular damage? So that's another thing which needs to be resolved. But there is substantial evidence that there is a link there. Now, a huge challenge is there are growing reports. I mean, one report was shared, one case was shared on the WhatsApp group today in Pakistan, where a clinician has been reinfected following recovery. So there is growing evidence that reinfection after recovery is possible, which raises questions about the longevity of the immunity against COVID-19. And that has implications for any potential vaccine which may be developed. How long would the immune protection be provided by the vaccine? Whether we'll need boosters, we don't know. And also, if you factor in the mutations which may occur in CoV-2 virus, that could further complicate the picture in terms of, the effectiveness of the vaccination. So there are huge challenges with COVID-19, and many questions still remain. We are all faced with, a growing amount of guidance and tips and, strategies to deal with COVID-19, both in, professional settings as well as in, domestic settings, public settings. But again, I'm sure everybody appreciates that the knowledge and advice is a constantly evolving phenomena with COVID, more so with many other things we've seen previously. And equally, expertise and research have been outpaced by the pandemic. I mean, I'm no expert, I don't claim to be an expert, but I don't think so. There is an expert in the world at the minute who can advise on all aspects of COVID. There are researchers and healthcare professionals who are experts in their own domains, but eventually it's bringing every evidence together and marrying it up to provide guidance to both the public and the professionals. And that's the challenge. We hear so much about various antiviral drugs, plasma therapy, etc., etc. But again, we need to appreciate there is no magic bullet there to kill the CoV-2 virus. No single strategy to limit the spread of this pandemic appears to be sustainable. Even with social distancing, we've seen the financial and social fallout from COVID-19 has been so remarkable that political leaderships across the world have had to balance it with the country's economies, livelihoods, etc., etc. So a lot of decision making you see both at the level of individual countries and internationally are influenced by the political climate. So these are some of the challenges. And I was just looking at the data as of today, and they're nearly, it's approaching the 10 million mark now, COVID cases, and there have been a good 467,000 deaths worldwide. And I'm not going to go into the entire detail of this. Obviously, everybody is aware of these figures. But what was most remarkable was that Pakistan has jumped 3 places. I've not included all the countries in the world within 24 hours. So it was around the 17th most affected country as of yesterday. And today, when I looked at it, Pakistan stands at number 13 with nearly 3,500 new cases and about 120 deaths. As most of the participants are from Pakistan, what needs to be rubbed in is that you're facing an imminent peak. And many of the guidelines we are going to discuss today have been written in countries which have at least partially passed the peak and are slowly returning to business, particularly dentistry. So whilst the guidelines are appropriate and up to date as of now, and they are very useful, what you need to appreciate is that in many countries, including the UK, there was no dentistry for a good 2-3 months. And dentistry resumed in England a couple of weeks ago. My colleagues can correct me if I'm wrong. But as for Scotland, which is one of the countries in the UK, dentistry is only going to resume from Monday. That is also going to be exclusively non-AGP type dentistry. Whereas Pakistan now faces an imminent peak. So you have to make wise decisions how you want to take it forward. And now I'll discuss some of the things we are doing. I'm not going to keep you long. I'm just going, because most of the knowledge is already there. It's in public domain. You are doing some very innovative things. I've been following the WhatsApp group feed. So I'm not going to bore you with every single thing, but I'll just discuss some of the things you might find interesting and some of the things we are doing at our institution, which you might find useful. Now, one of the things which appeared a bit remarkable for me from the WhatsApp group was that nobody was discussing risk assessment to staff, and that staff across the board, you as the dentist, your assistants, nurses, hygienists, etc., etc. And what we've done at our institution is, because safety first, if you are not safe as a clinician, then obviously that's not the right approach. So what we've done at our institution is we've developed a risk assessment tool for staff, and it is based on certain risk factors. I'll just go through those. So if you are over 50 years of age, hopefully most participants are young, and I'm approaching 50 now, so I might fall into that bracket. If you are over 50 years of age, that adds 1 point risk factor. Over 60, it's 2. Male gender, 1. I've heard this a lot on news media that Pakistanis have a higher level of immunity. I don't know where that came from, but in the UK, the BAME staff, that is the Black, Asian ethnic minorities, they are considered to be a higher risk, and there is some evidence to back it up. So the Asian Black ethnicity is an additional risk factor. In terms of the health, BMI greater than 30 adds another point. Chronic heart disease, chronic lung disease, 1.5, diabetes, 1.5, likewise kidneys, immunosuppressive therapy, that's 2, cancer, neurological conditions which impair respiration directly or indirectly, sickle cell disease, pregnancy. And summing up all these factors, we carry out a risk assessment for staff. So anything under 4 is a low risk, which means they can provide treatment in clinical environments. High risk is anywhere between 4 to 7, which means that you would avoid patients who have who are known COVID patients, and you would avoid AGPs, and then as much as possible. But with very high risk, you should not be in the clinical environment. That is anything over 7. So I thought that thing was probably not discussed, or not to my knowledge, and that's not something which is, I think, not happening in Pakistan. Professor Samir, can you please share with me this risk assessment? Has it been discussed, or am I wrong?
Sorry, I was muted. No, not to my knowledge, it has not been shared. I'm at 5 and I'm concerned what I should do.
Yes, well, I hope you're safe, but it's something I thought hasn't been discussed in the Pakistani platform. So it's something you might want to consider. Now, all the things I'm discussing, I'm not saying what is the right thing to do, what is not right, and I'm not advocating anything, but I'm just sharing with you what we are doing, and it's up to you how you want to buy this information to apply it to your own settings. Remote screening and triage, I think there is a fair amount of knowledge. I've just picked this up from the Scottish guidelines. On the right side of the slide, you can see these are some of the symptoms of COVID: new continuous cough, high temperature or fever, loss or change in your sense of smell or taste. So if patients have these features, you would want them to have appropriate COVID screening and testing before you see them in your practice. In the UK, of course, urgent dental care center hubs have been developed where these patients can be treated, but you want to, evaluate whether your practice is, or your institution is, fit enough to treat these patients. And it would be helpful if you put up a notice. Obviously, practitioners in Pakistan, I've worked there for long, and I know everybody works differently, but my suggestion would be that you put up a notice at your practice at the entrance, which is very similar to this. Obviously, you can translate it. So you might find it useful that you only carry out triage distantly, not face-to-face triage, at least not the initial appointment. And once you are confident that these patients need face-to-face consultation or treatment, then you can bring them into your practice. So that might be useful. I know it's not happening across the board in Pakistan, but that would be my suggestion, at least during the peak. And once the peak settles down a little bit, hopefully, then you can make changes accordingly. So you identify the risk of COVID based on the patient's medical history, their symptoms, and then evaluate the need for dental treatment, which may be advice, analgesics, possibly antibiotics. Now, antibiotics is something to prescribe antibiotics or not, but I think
It's all right. I was just forcefully muting everyone. Now that everybody's muted, they cannot unmute themselves, and so we'll have them unmuted only at the end of the presentation. So you can go ahead with the presentation. There is no issue with the sound. If that stopped you.
Okay, just bear with me. I'll have to stop sharing because, okay, can you hear me?
Kamran, we can hear you. And just a quick question about smoking. Is smoking a risk factor? Should that be in the list?
Yes, so smoking hasn't been, we all know smoking is a risk factor in so many ways, but in terms of the guidance we've developed, unless there is chronic lung damage, then not in isolation. If there is evidence of chronic lung damage, then yes, which probably is most likely to be due to smoking. But if there is no evidence of disease, then maybe not. We haven't included it at least. Now, in terms of the antibiotics, I think Professor Samir rightly pointed out on the WhatsApp group, it's only for spreading infections you would prescribe antibiotics. And even prior to COVID, there is no way you can stop dental practitioners from prescribing antibiotics. Everybody claims they're not, but the reality is different. So, and also if there is a spreading infection, which is life-threatening, the patients need to be treated as inpatients in a hospital setting anyway. So really you have to think twice if you are prescribing antibiotics for pulpitis and the rest of it and perio conditions. You just have to think twice. But it is an option, but it has to be an informed decision making based on guidelines. And I'm not going to discuss that at length today. Face-to-face appointments are most likely to be warranted if there is non-resolving pain, oral or facial swelling, prolonged bleeding following, say, an extraction or trauma. Those are the key conditions where you would want to bring the patients into your practice. And again, I'm saying, I realize I'll be repeating myself, but I think I have to. I'm not saying what you should or shouldn't do. That's up to you as a professional. You're a qualified professional, but I'm just sharing what we are doing at our institution. So that's the second thing. In terms of the personal protective equipment, I think that's one of the most talked about things at the minute in dental communities. Again, I'll share what we're doing. So good hand hygiene is fundamental. It was always fundamental, but perhaps we only realize it now. You read any guidance on cross-infection control pre-COVID, good hand hygiene is fundamental. So that applies to any sort of environment, whether it's the waiting room, dental surgery, AGP, non-AGP. So that's universal. Disposable gloves, we're not advising in the waiting room, but obviously for all clinical procedures. Disposable plastic apron, primarily for non-AGPs. Disposable gown, primarily for AGPs, and obviously I've seen many dental professionals using coveralls. They are perfectly fine, maybe better. So disposable, non-permeable, splash-resistant gown, that's what we are using at our institution. A fluid-resistant surgical mask, yes in the waiting area, yes in dental surgery, but for AGP procedures, what is recommended is a face-fitting respirator, and I'll talk a little bit more about it. We are using FFP3s for AGPs, and it's perfectly fine to use FFP2s or N95s. They're recommended by WHO, and even in the UK where FFP3s are not available, you can use FFP2 or equivalents N95s. And I would appreciate here Dr. Salman Ashraf, who's shared, huge amount of resources about long life mask options from 3M, which you can use for, up to a decade. And most need replacement filters only after 3 months. And there are a host of options available. And I'm sure we can all look up online and look at those. So whatever option you choose is fine. The only thing what I find is probably not the best in Pakistan is the fact there is no professional fit testing available. And that is a huge challenge. The fit testing you do by checking the flow of air after you fit the mask on your face is fine, but it doesn't replace the need for fit testing, at least for the first time you're using a particular piece of equipment. And I'll just share a resource which is available on the YouTube, how to carry out fit testing for respirators. And if you look at it, to be honest, it's replicable. And I know at our institution, several nurses have been trained in doing fit testing. And I'll look towards Dr. Hassan. If you can, provide that training, that would be ideal. Again, I'm saying that's ideal. It's up to you which mask you want to use, but that's what we are using, FFP3. We haven't quite moved to the more elastomeric based, long life ones, but that is an option. Eye protection. Now we've been talking a lot about respirators and the risk of from aerosols, etc. But there is some department which some evidence which has been shared by the Department of Health in the UK that actually eyes are the biggest risk. So it's something we need to be aware of. So eye protection is absolutely mandatory. We haven't recommended it in the waiting room or reception area, but it's something you can debate. But certainly in clinical environments, eye protection is absolutely mandatory. Surgical caps, interestingly, obviously you don't necessarily need them in the waiting room area, but some of the guidance on AGPs, which is available in the UK, they don't talk about surgical caps. And I think surgical caps make sense. So that's what we would recommend. And finally, shoe covers. I mean, it's a two-edged one. Shoe covers, there is a significant risk of, tripping over. So you have to be mindful about that if you're going to use shoe covers. So that's something you need to be aware of. And again, I'm sure you've had this information provided to you ad nauseum. Again, I'm not going to go through that. I think I've already covered that N95 is equivalent to FFP2, and they provide up to 94% filtration of particulate matter, including COVID, whereas N99 ones, FFP3s, they provide up to 99%. And for AGPs, that is probably the best. But if you don't have those, N95 would do. And again, whilst you have the option of going to N100 if you were a bit overcautious, but the existing evidence doesn't necessarily advocate the use of N100 in clinical environments. So this is the resource. What I'll do is I'll share a copy of the presentation with Dr. Hassan, and so you can have all these slides, and then you can check up this resource. Fit testing isn't particularly difficult, so you can do it. And obviously in Pakistan, we have many people who have beards, and there are other options available like this power air purifying respirator hood, but it's easier said than done. How easy is it to perform clinical dentistry with all this paraphernalia, and also with this, the exhaled air from the clinician wearing this, the patients aren't protected. So that's the other issue with it. But there are a host of other options available if you're struggling to have an appropriate respirator because you've got a beard or any other issues. I'm also sharing these pictures with you in terms of donning and doffing the PPE. And apart from the availability of PPE in Pakistan, what sort of PPE is available, the costing, and whether it's financially feasible to use so much PPE for procedures for which you're not charging enough to cover your costs, that obviously is a huge issue. But ideally, the donning and doffing areas should be different. So there should be a clean donning area and then a dirty area where you can doff your PPE. So that's something. And again, I realize it may not be possible for many practices in Pakistan, which are basically a single room practice in a commercial building. So again, There is no straightforward answer to that, unfortunately. Um, the only thing I'd share, and I know Dr. Adil is here and we've been discussing it, the Department of Health guidance is for doffing the PPE is that you take off your gloves first and then remove your gown or apron. That has been changed to from the previous guidance where you would remove your apron first. So that is the existing guidance and it's perfectly appropriate, but equally, I know in some of the NHS hospitals, the feedback from the staff has been that they're not particularly keen on taking off their gloves first. So there is some controversy there, and I'm not only highlighting it. I'm not saying which one is more correct or which one is worse, but it's something you need to be aware of. And as I said, I'll share these pictures with you, so I don't really need to go into too much detail because you already know these things. Some of the SOPs for clinical sessions, again, at the cost of repetition, review the triage information prior to the appointment, don your PPE in a clean zone, ensure that the adjoining surgery door is closed as soon as possible when you enter the surgery with the patient in your surgery, complete medical history verbally with the patient in the surgery. I mean, medical history is a massive issue in the UK. You have to demonstrate that you had taken an appropriate medical history, updated it regularly. I know it's not a huge issue. We just, are used to asking 2 or 3 questions. Are you generally fit and healthy? Do you have diabetes, high blood pressure, and that's it. But in the UK, it's something we do a bit more methodically across the board. I'm sure there are clinicians who are even more prudent than us in Pakistan. I'm not criticizing, but on a general note, medical history is something you need to confirm. What you took over the phone, the medical history, you need to confirm it verbally. And then you undertake your clinical assessment for the treatment needs. Use of mouth rinse where appropriate. I'll discuss it in a bit more detail. What's the evidence behind the use of mouthwashes which may contain antiviral agents? I'll come back to it, but that's why I've put it, use of mouth rinse where appropriate, because equally, whilst it may be protective, when patients rinse and spit out, there may be a lot of splatter, and that may be, may actually increase the risk of spread of infection. After completion of your clinical treatment, doff your PPE in the dirty zone, and you should have somebody watching over you. And the culture and the hierarchy in Pakistan is such that I wouldn't expect your dental assistant to challenge you, whom you've employed, or your receptionist to challenge you, but it's a culture you need to build where people can challenge you if you're not doing things right, and that's the only way forward. So I'm sure we are all adults and we understand this point, and it's something you need to be doing quite openly as a professional. For non-AGPs, again, ideally you would space appointments. What we are doing is we have a 20-minute fallow period in a single room for non-AGPs. And I know some of you may not be doing it, but it's just a suggestion. For AGPs, which should only be done when essential, ideally schedule at the end. I wouldn't expect many dentists to be doing 40 AGPs in a row. Schedule time for procedure and time for decontamination. Use of high volume aspiration and rubber dam. Sorry, the word dam is missing there. That's ideal and mandatory. Well, not even ideal, mandatory that you use high volume aspiration and a rubber dam wherever appropriate for AGPs. Obviously, you can't do that with surgical extractions, so there are exceptions. And we are using a 60-minute fallow period in a single room with, say, 6 air changes per hour. Now, if you have a negative pressure environment built in your surgery, that may be reduced to 20 minutes. That's our understanding. And I know it's being applied very differently in different places. And even in the UK, the people are using, the air exchange calculations very differently. So I'm not going to say which one is right or wrong. I'm just sharing what we are doing. And I also know, Dr. Salman again shared some very excellent resources where resources have been published which highlight new innovations in dentistry with isolation systems, a high speed vacuum hose, etc., etc. And we'll talk about those a bit later when I talk about research. After treatment, escort the patient to exit immediately. All the discussions, follow-up, discussions can take place over the phone, including payment arrangements, future appointments. But if for any reason you're doing it face-to-face in the reception area, you must have appropriate SOPs to minimize the contamination. Classification of clinical procedures. Again, there are some controversies, and I'll talk about those. But basically, AGPs, wherever you're using a high speed handpiece for routine air rotary for restorative procedures, surgical handpieces, high speed or micromotor based surgical handpieces, we're using saline irrigation. That, based on our understanding, is an AGP. Likewise, use of ultrasonic, sonic scalers, slow speed drills which you run wet and dry, where there is irrigation, that, based on our understanding, is an AGP. If you're removing caries using a slow speed handpiece without irrigation, you could treat it as a non-AGP. And also high pressure 3-in-1 syringe when used together. So obviously, if you use air and water separately with a little bit of time interval, then you can treat it as a non-AGP. Air abrasion or intraoral sandblasting, again, is an AGP based on our understanding. And then there is also the issue of, which has been highlighted very nicely by FGDP, the aerosol generated exposure as opposed to aerosol generated procedure. Whenever you have patients in surgery, whenever they cough or sneeze, there is aerosol generated. Whether you call it, I know Professor Samir has some views on it, but whether you call it splatter, water droplet, whatever you call it, but it does increase the risk. So when you are thinking about AGPs and non-AGPs and the relative risk, you also have to consider the time the patient spends in the surgery. So if you're, for example, doing an access opening with a high-speed handpiece with a rubber dam in place and a high-volume aspiration, that might be less risky in some ways than somebody who is in the surgery for a good 60 minutes where you're doing scaling and route planning with hand instruments. So it's something you may want to consider in terms of the time the patient spends in the surgery. The shorter, the better. There is some very good guidance available from the British Orthodontic Society on AGPs specific to high-risk procedures specific to orthodontics. And I'm not going to cover it, but I've provided the link. It's freely available. Even if you're based in Pakistan, you can download that. And I might at some point ask Dr. Adil if he's happy to share as an orthodontist. Management of the clinical environment. Surgery door closed during treatment whenever possible. I know it's not possible for all dental surgeries in Pakistan which have an open reception surgery area. Keep exterior windows open and ideally windows on either side of the room for cross ventilation. AC, I know, is quite a controversial area, but our understanding is that if you have windows open where there is cross ventilation and the AC has an extraction mode only, you can use ACs. So that's again debatable. Obviously, air cons run on a recirculation mode, or where you do not have rooms with windows, then it's an absolute no-no. And then you have to think twice whether you want to do AGPs in your surgery or whether you want to incorporate any additional mechanical measures for air extraction. Adjuncts like HEPA filters, ultra-low particulate air filters, etc., are adjuncts, air purification systems, but in their own right, they the evidence, I think, is developing in the context of COVID. But certainly they do help, but I would treat them as adjuncts rather than providing protection on their own. And there is the table from CDC about air exchanges we can look at. So based on that, 6 air exchanges, you need a fallow period of an hour, up to an hour, for 99% clearance. I'm coming towards you'll be pleased to know I'm coming towards the end of my presentation. That's why I didn't take so many questions, but I will stop before I discuss some research, etc. So this is the last slide I'm going to talk about. FGDP have very nicely highlighted some of the human factors which come into play when faced with such catastrophic conditions like COVID. Stress is a huge one for the practitioner, the staff, and possibly also the patients. But what I find particularly relevant is complacency. Complacency can creep in any moment because you can only remain focused for so long. So it's something, you need to be mindful about. And that's why I said you need to change the culture in your practices where you can be challenged even by a cleaner, for example, or by your assistant. I know that isn't the culture. And to be honest, that isn't the culture even in individual practices in the UK. It's very difficult, but certainly in institutions, I know even as a professor consultant, I can be challenged any moment by a cleaner. I know we've built that culture. I can be challenged by a student. They wouldn't fear that I'm going to fail them in the exam. They can challenge me outright. So it's something you need to, if you're not complying with the guidelines, your peers should challenge you. That's the culture you need to build. Distraction is a huge one. All the WhatsApp groups, messages on COVID-19 group, that's a distraction. Lack of teamwork, lack of knowledge, fatigue, lack of assertiveness. These are some of the human factors which can creep in. And what I see in Pakistan is, obviously, I've talked about it repeatedly already, the imminent peak of the pandemic. As I said, dentistry is only resuming in UK as we speak. It will resume in Scotland on Monday, non-AGPs. You talk about financial constraints, trust me, there are huge financial constraints for dentists in the UK as well, which is obviously a richer country. People have invested hugely in their dental practices. They've taken mortgages, they've taken innovative new equipments on loan. It's a huge issue. And I know several, a lot of practices have gone bankrupt. Many are closing down. It's not easy even in the UK. And obviously you will, based on, your individual circumstances, your earning potential, financial constraints is a huge issue. And that might tilt your approach, which way you want to go during this peak period, whether you want to carry on, whatever. Lack of resources, logistics is again a huge issue in Pakistan, more so than in the UK. But equally, I can tell you, it's not easy to source PPE even in the UK. There are struggles involved, and there are more struggles involved in Pakistan. But as highlighted by someone on the group today, flights are resuming in Pakistan now, so you would expect a more rapid flow of PPE. So that's a sign of hope. And the biggest challenge in Pakistan is limited professional support nationally. And I don't want this session to turn into a mutual praise session. Professor Samir rightly highlighted it in the group as well. That's what not these activities should be about. But I would certainly, I'm not shy to praise Dr. Hassan for taking massive initiatives which are unprecedented. And that's what the role of professional dental associations, or any professional association for that matter, should be, to guide the stakeholders, guide the professionals. And now at least you've got some form of, a platform. I'm sure there are other platforms in other cities, but that's the one I know. And it's something really commendable, and it will make a huge difference. And then you have amazing expertise in Pakistan who've been helping you, Professor Samir, Professor Abid Ashar. I'm just naming a few people. Dr. Salman has contributed very positively. He's shared some excellent resources in the group, with the group. And And then obviously you've had, further advice from all the colleagues in Pakistan and from Professor Adnan Shah in Canada, Dr. Kashif. So you have, a lot of help available now, but it's something, which is being highlighted during this pandemic, that the profession needs to come together. There are, separate issues in the UK, particularly from a financial standpoint. And I can tell you, dentists across the board aren't happy how things are going at the minute. So you're not alone in it. And the incredible amount of guidance we've got available in the UK from 10, 15, 20 different resources, it's not easy to marry it up together. So there are challenges in the UK, there are challenges in every country. But I think what we need to do as a group is develop this platform with the initiative from Dr. Hassan and his colleagues in PDA Gujranwala, and take it forward, not only for this pandemic, but we need to carry it further for the foreseeable future. So I'll stop here. I'll stop sharing for now, and I'm happy to take questions and then see if I can answer. Obviously, I'm not an expert. I'm just sharing with you what we are doing. More than happy to answer when I can. I'm happy to take questions through Professor Samir and Professor Adnan. Aslam.
Kamran, thank you so much for your presentation so far. I'm looking forward to what you're going to present about research as well. So the really interesting thing about your presentation was that there were questions coming up in the chat, and then within the next couple of minutes, you'd answer them. So, I would note them down, and there are very few questions really left because you've answered everything. Possibly you could say a couple of words about testing, because there are a couple of questions about, testing, not to test, when to test. So maybe if you have something
Testing
to say.
for COVID, you mean?
Gee, I can read out this question for
Yes,
you.
so testing is helpful. That's what I would say. But then when we are at a stage where we know now that reinfection is possible, so, and testing may not always be feasible. So where feasible, yes, why not? There is no reason not to test. Everybody should be tested, but testing alone is not something you can rely upon. Obviously, I'll talk about research where you can have chairside testing with the development of nanotechnology. I'll talk about it in a minute. But yes, if testing is recent and you are confident that they haven't had any exposure subsequently, then yes, but it's easier said than done. What if they tested negative yesterday based on the antigen test, and they might have acquired the infection, but they don't have the symptoms? So I don't think so. There is a straightforward answer, and I'm happy to be led by yourself and other colleagues. But my answer would be wherever possible, yes, but how much you can rely upon it, I think you have to consider other factors.
Kamran, thank you very much. Now, you've basically answered everything, but there were a couple of questions in the chat about disinfection of masks. And
Yes.
just say, and maybe if you can sort of talk a little bit about that.
Yes, so disinfection of the mask is recommended, but the challenge with some of the masks is they would get deformed, particularly the respirators. And if they get deformed, they're no good. And I'm quite inclined about the idea which was put forward by Dr. Salman and other people in the group about using, long life masks, which would last for up to 10 years. They can be cleaned. The filters don't need to be replaced every day. It's looking at approximately 3 months. So that might be the way forward. But yes, you can use appropriate measures to, disinfect the mask as long as they don't get deformed. And the other thing about disinfection of the clinical environment, the only reason why I didn't talk about in detail, you've previously talked about, Professor Samir, you've done it, and I don't think so I can add anything to that, particularly for, be it alcohol-based preparations or hypochlorite or whatever, soap, water, whatever you're using, whatever is available to you. I think the only thing is, even in the UK, we are now mindful that we don't use commercial cleaning, wipes. because they're not good for the environment. They're very expensive. Already we're spending so much on PPE. So maybe you can use normal cloth as opposed to wipes. That would be my suggestion. But I think you've already covered it in your presentations. They're all alcohol-based, hypochlorite-based disinfectants. Whatever is available, you could use that. Thank you.
Thank you, Kamran. And maybe I can just say to the audience that autoclaving is not recommended for these N95 masks, and liquid disinfectants should not be used on them. And even hydrogen peroxide is only compatible with a certain limited number of masks, which are the list of which is available on the CDC website. So, you know, Kamran, unless there are any questions from any of the audience members, maybe you can continue your presentation and finish off, and we'll request them to again refrain from noting unnecessary things in the chat and just note down just the questions or things relevant to the presentation.
Okay, thank you, Professor Samir. I think I have missed a slide, and the slide was about sterilization and disinfectant. I think I've missed it. It's been deleted from my presentation, but I'll just talk a little bit about it before going ahead with my presentation. And what I want to say about sterilization is, it's something, you know, many of us are particularly sensitive about, and something we've seen there is a lot to be desired in Pakistan in particular. Even in the UK, in general dental practices, not always they fall, you know, they comply with all the expected standards. But I think the gap is bigger in Pakistan. And I think you should treat it as an ethical issue, less so as a clinical issue. But obviously, if you're not providing safe clinical environment to your patients, how do you expect whatever your belief or faith is for nature and God to protect you from COVID or any other calamity? So I know Professor Samir has championed cross-infection control in Pakistan, and maybe it's an opportunity for everybody to reevaluate their sterilization and cross-infection control. It's not specific to COVID. You need all those standard protocols for your practice anyway. And if you're not doing it, you really have to, you know, pull up your socks. Obviously, I would mention here how we were exposed to excellent cross-infection protocols in surgery 2 at De Montmorency, and hats off to Professor Saeed and Professor Adnan who developed those protocols. And I think there is a lot to be desired in general dental practice environment in terms of sterilization. The PPE and all the other measures, air exchanges, they are not going to rule out spread of blood-borne infections like Hep B, Hep C, HIV in clinical environments. So please don't forget those. So I had a full slide on it, but I'll leave that for now. And I'll come to some of the research which is being contemplated here. We talked about the effectiveness of mouthwashes. Obviously, oral cavity is only one region here where you've got the viral load. Nasal cavity is the other. And when you generate splatter, when you generate aerosols in clinical environment, you're not only looking at the oral cavity, but also the nasal cavity. So an idea was put forward in a letter in the BDJ a few weeks ago by somebody where they were advocating nasal sprays based on povidone, iodine, both for the nasal cavity as well as mouth rinses simultaneously, because there is evidence that 15 seconds contact time may be sufficient for antiviral effects. And in vitro studies confirm the effectiveness of povidone iodine against CoV-2, SARS-2-CoV. And I've quoted the paper at the bottom of the slide. But at the moment, I think evidence is developing, so you can't rely on it. It's just something we are also exploring, how to you know, build evidence around that area. The challenge with viruses is if you identify a virus, it doesn't necessarily mean with whether it's dead or alive, because it's an obligate parasite. So unless you use bacteriophages or bring it back into a human host. You don't know whether it's still capable of, causing disease, or if you do viral culture, which isn't easy. So there are issues around research with viruses, but it's a potential area. What we are actively exploring at our institution is use of dental water lines containing antiviral agents. So the water which comes in your handpiece already has an antiviral agent, and the droplet and the aerosol which is generated uh, has the antiviral agent in it. So that might have an effect. And again, there are lots of issues to consider. We routinely use the ICX antimicrobial in our dental unit water lines in one of our facilities because of uh, Legionella in that environment. Um, and that's something we are actively exploring. But again, there are huge issues around it. Chairside testing of COVID would be ideal. So you were talking about testing. So the patient comes to you, you take their saliva, a drop of saliva, put it in a small device, which is the size of a keyring, attach it to your computer. So that's the Minion technology. I'm not going to talk about it. So you don't need any elaborate equipment or anything, just a handheld device. You pour a drop of saliva on that Minion and connect it with your computer. It would run tests based on the library where the genetic typing of the virus or any bacteria has been done, and it will give you immediate results. But it's a developing technology, and then again, there are issues, but that might be the future. Obviously, COVID-19 is an issue for now, but long-term, the Minion technology has an immense future. So when the patients come to you with dental abscesses and periodontal disease, you can do chairside microbial screening. That would be ideal. And it's something which will impact on COVID screening as well long-term. I think it's already happening, but I think the technology is still developing. And lastly, the development of aerosol isolation systems. Salman shared a very good paper which talks about aerosol isolation system, a bespoke aerosol isolation system for endodontics, where there is a impermeable screen attached to the microscope, and there is employment of a high volume, high turnover suction hose. And you can read that paper, and there are lots of other papers coming out, technologies, innovations coming out for developing aerosol isolation systems bespoke for dentistry. And it's something, I'm not going to say which one is right or wrong. I think it's a developing technology, but that is also a possibility. And I know some of you have been developing those. And the only comment I would have about those systems is you need to be mindful about the environment where your isolation system vents the air into the external environment, whether it's on a rooftop or wherever. Ideally, you should have an appropriate filter attached to that system, because you don't want the general public to be exposed to those. And that's also to do with where you're running air cons when doing AGP procedures. So that's something to consider. I'll just share with you a novel negative pressure otolaryngology viral isolation drape, which has been developed in the US by some ENT surgeons. I know you won't be able to apply to dentistry, but there is another reason why I'm sharing it. Now, this isolation system consists of a transparent plastic film, as you can see on the patient. Obviously, this is suitable only for surgery under general anesthesia. And it employs a Lone Star disposable ring retractor, the blue one, coupled with the Book Walter retractor laparoscopic support set. And you can drape the patient into this isolation system and introduce your suction and other instruments into the patient's mouth through very small holes. And just next to the white arrow, you can see that it has a high volume evacuation system to evacuate the steam which is generated from electrocautery. And you can't see it in this picture, but there is also a high volume aspirator which has a HEPA filter attached to it. The ultra low particulate air filter attached to it. The blue one is the HEPA filter. And they developed this system, and they carried out evaluation of the aerosol in the theater environment using fluorescent dyes, which can be viewed under with the help of a wood lamp. So the patient rinsed with, they introduced, obviously the patient was under GA, they introduced the fluorescent dye into the patient's mouth and nose, suctioned it, and they reintroduced it throughout the procedure, lasting for hour or hour and a half. But obviously they only used endoscopes for this surgery. So they didn't need the vision you need in dentistry. But the reason I've added this paper here, I reviewed it for the journal, that even after such a, well-developed isolation system, which was impermeable, and the only entry points were quite snug fit, where you introduce your, suction and your, not even the suction, the endoscopes and other apparatus, instruments. Even with this type of apparatus, there was evidence of aerosol on the surgical gowns of the operator and the nurses, on the surgical instrument trays, and in other areas as well. So all I'm trying to say is, the take-home message is, whilst you are employing high evacuation hose, spending so much money on it, on any innovative isolation system, you need to be mindful that nothing provides an absolute protection. So avoid AGPs as much as you can. And it's a case of, taking the risk. The risk is low. Fortunately, the risk, we are probably overinflating the risk with aerosols in some ways. The risk is low, but again, because it's a potentially fatal disease, so you'll do everything to protect yourself, your family, and your patients and the public. So I thought this is a good example to highlight that no system can ever be absolutely perfect. So these are some of the resources we are using in the UK, and you can download the guidance based in Pakistan. I think Salman has already shared it on the WhatsApp group, and other people can download it. Now, guidance is based on science. And I know science is forgiving in some ways. It doesn't factor in faith. But what science has shown us during this pandemic is that mental health is a huge issue for clinicians in particular and public at large. And what is being recommended by science is now meditation. And I'll just share with you something which I practice as a Muslim. I know there are people in the audience who may not be Muslims, and they might want to practice it based on their own understanding, belief, how they want to meditate. So I'm not advocating it for everybody, but I know there are people in the room who are mostly Muslims. So my apologies to the non-Muslims. So this is, there are numerous supplications in the Quran. Each one of is absolute gold. But I thought this one is particularly relevant. This is what the men of Angelos, the Ashab-e Kahf, we call them, the companions of the cave, they use this prayer, and it's mentioned in the Quran, when they faced a major persecution by the Romans. And it's something I think is very relevant to the situation. رَبَّنَا آتِنَا مِن لَدُنَّا رَحْمَةً وَهَيِّئْ لَنَا مِنْ أَمْرِنَا رَشَدًا. Our Lord, bestow on us mercy from yourself and facilitate for us affair in the right way. So we are faced with a catastrophic condition with this pandemic, and I thought this was relevant. I'm just sharing my thoughts. It's up to you how you want to, what you want to read and what you want to do for your meditation. But connecting with God as a Muslim, I think is something which will help our mental health. And obviously people who follow other faiths or no faiths, they can find other ways to meditate. So I'll stop sharing my screen here now. And now we can freely take questions. More than happy.
Kamran, thank you very much. It was a real pleasure listening to your presentation. And, just makes me sort of just hammers in, the fact that you've left us in Pakistan. And, it's such a loss. There are people who like stars, and you're shining somewhere else, but you're still shining. And we're so grateful for your time today.
Thank you for your kind words, Professor Samir. I mean, honestly, yes, I realize it. I've left Pakistan and I haven't contributed much but you'll be pleased to know that it has been on my agenda, and Adil knows more than most people in the audience that I've been actively pursuing doing some work in Pakistan. Um, but it was only because of I was there last summer. I went to FMH. Khurram kindly facilitated that. I went to Nishtar, elsewhere, other places, and I'm actively looking at engaging with the dental profession in Pakistan. And hopefully, once COVID settles down, you'll see a lot more of me, till you might want to get rid of me again.
Thank you so much, Kamran. Thank you so much for your thoughts, because I've always, felt that the brightest amongst us, we go out for training and then, or for whatever reason, and then they just keep us there. And you were one of, the really bright stars. And
Minded, we've got Professor Adnan, we've got
yes,
Adil, Dr.
you
Kashif.
took the words out of my mouth,
They need to be
because I
pulled
was
back.
going to mention, Dr. Adnan, Dr. Khalid Almas before, and then there's a whole line of, very, very brilliant people who unfortunately, are no longer with us in Pakistan. Dr. Adnan, though, is here with us today. And in a minute, after the questions, I'm going to request him to please say a few words. The interesting thing, as I was mentioning, is that you've kept answering all the questions even during this research phase last little bit. So there are very few questions left. Maybe there was one question about triage in a large hospital where there are hundreds of people, sort of coming in for work. I think it mostly relates to triage of the dentist or the dental healthcare workers. And you did mention, your risk management for staff, but I don't know if there's anything else you can add to it.
Yes. So obviously, uh, in the UK, people are advised. I know for my GP surgery, I can't walk into my surgery anymore. So that's the general medical practitioner surgery. I have to contact them first. And if I have symptoms, I can't go into the surgery. I have to self-isolate, all the guidance you're already aware of. With hospital, I think my understanding is it's only for accident and emergency where you can walk in. But for other areas, you would be expected to have an appointment before you come in, and they'll screen you appropriately. It's difficult. It's difficult in Pakistan. I don't know the answer to it, but the least I think practitioners can do, at least during this imminent peak, is that they can have a notice placed on their main door that patients shouldn't walk in. They should contact them by phone. And I'm sure we will see technologies developing where you can use videos to triage patients, look at them, have face-to-face conversations. And one thing I must add here, I know there is a lot of discontent with uh, um, remote consultations in Pakistan because you don't get paid for it. In UK, at least for the NHS, you can get paid for it. But uh, the challenge in Pakistan is how do you take payment from these patients? And I don't know the answer, but I think it's a huge opportunity for dental professionals in Pakistan, where they can exploit, payment platforms like Western Union, etc. You don't have to be registered to receive a payment, and develop something which they can use long term. So they can provide consultations to patients beyond COVID, and that might enhance their earning potential. And I'm not going to talk too much about it, but I'm confident there is a way around it. With the technology available, there are, so many millions of smartphones in Pakistan now, WhatsApp video, FaceTime, there are options available for remote consultations. And I know, again, Dr. Salman is doing a survey on teledentistry. Uh, I think use it as an opportunity to develop a form of a system where you can actually charge patients for remote consultations. That's my take home message. How you do it, it's not straightforward. I know that, but I'm positive there is a way around it.
Kamran, thank you also for ending with that case that you showed, where, despite all those precautions, the aerosol was still coming out, which just indicates the importance of protecting your mouth and nose. You want to say something?
Because you see, you would still be, bringing out all the instruments back to the instrument tray. So some form of aerosol is going to come out, even how well isolated the system is.
So a couple of words maybe about UV light and fumigation, because these are two things that are being promoted nowadays.
Oh, there are a million things being promoted, Professor Sagar. I think ultraviolet.
There was a question about it, so I asked.
Yes. So UV light has a role to play. I think it can play a positive role in improving the surgery environment. Uh, what is the best system? To be honest, in my capacity, because I don't run a practice here, so I don't look into the actual logistics as much. But what I know is UV light can help the environment, the surgery clinical environment where the viral load is high. So that's that. The coating the surgery with hypochlorite based solutions. I think the advice at the moment is we don't know how much is their effectiveness in terms of controlling the viral load, and B, there are surely effects which we don't know, the harmful effects of hypochlorite based solutions. If you use them injudiciously, I think there is a risk. So it has to be a balanced approach. That's my understanding. Sorry, I didn't add much to it because it's not my area of expertise. My nurses would look after the environment. I just have to oversee them that they're following the procedures. But I'm not an expert in this area. But yes, I certainly would say ultraviolet, if you can employ it, yes, it would be helpful.
I just have one last question from the audience, and I'll read it out in case you can understand it. What should be done if we have a common OT where not everyone may be adherent to SOPs? What can we do other than PPEs in such situations? It's a tough one.
Again, it points to a peculiar situation, which is not unusual in Pakistan. We had all sorts of arguments with our medical colleagues in the theaters at Yucky Gate when I was there. Again, it is something probably you would take all the precautions you could. It's a common sense answer. It's not no science here. And probably take it up at the administrative level, raise it at an administrative level as a team, as a MaxFax team. That's all you can do. That I don't know. I mean, I can answer this question any better than anybody in Pakistan.
No, nobody can answer this question. Thank you so much, Kamran. It was such a pleasure. And, I wish that this presentation won't end and we can sit here and chat with each other. But if there are no other questions, if any audience member would like to ask a question.
There are a couple of things that we probably would have wanted to ask him. And this basically pertains to the possibility of viral load or repeated exposure playing a role in causing more severe disease. And this has a background and a clinical implication in the sense that possibly the healthcare professionals are seen to have more moderate or severe versions of the disease or spectrum of the disease. So has there been some evidence on it, or it's just because we get to know about them, so we think that it strikes them more?
I think the evidence is developing when you see, several thousand new cases of COVID every day, hundreds of fatalities, in so many countries. So the evidence, I would say, is developing. Clinical environment is a high risk environment, irrespective, especially where you have, procedures like we do in dentistry. And one reason might be that, obviously when a doctor dies, unfortunately, it's highlighted more in the media. So you have to look at it in both ways. But the straight answer, as much as I know, would be clinical environment is a high risk environment. And in addition to the million factors we don't know about COVID, what we do know is the higher the viral load, the more severe the disease is potentially going to be. So I would treat it as a high risk environment. And, I would assume as a clinician that more serious implications of the disease may be seen amongst clinicians. Again, I don't think so anybody can answer this question, but I think the evidence is developing as we speak. I know FGDP, my colleague, Dr. Ian Mills is the dean, and even with SD, Professor Jeremy Bagg, he's a colleague as well. He's our external examiner. I think they've commissioned new areas of research to update their guidance. But the good thing with the FGDP guidance in particular is that they've acknowledged where the evidence is lacking. So if you read that guidance, you will identify many areas. But coming back to your question, that's all I can answer. Clinical environment is a high risk environment, and there is a understandably high risk of severe disease. because of the high viral load.
Thank you very much. Has there been an advisory by the NHS on doctors if they contract it and they are at home? Are there some basic medications that they can start off at home if they only have mild symptoms? And so, has there been an advisory like this?
So my understanding again is that if you're diagnosed positive, you're without symptoms, you just need to self-isolate. If you're diagnosed with mild symptoms, you would go for, paracetamol type stuff. But when obviously the symptoms become severe, then you would seek a hospital consultation. I know so much has been talked about medications, and every new medication is being oversold, particularly in Pakistan. I would just raise, I've shared it, my thoughts on the WhatsApp group, the plasma therapy. Now that we know that reinfection is possible, what's the life of the antibodies which are produced by an infected person? What's the benefit of it over a period of time? We don't know. And likewise, when somebody is infected, I'm not sure if they're doing antibody titers for the plasma they get from the donor before injecting it into somebody else. Just the fact that somebody was infected, you take that plasma and inject into somebody, doesn't make sense to me. Equally, how long those antibodies are going to last. So I think, I'm not saying, if I were infected, God forbid, I would get my hands on to any available treatment. So that's not what I'm saying, that don't take treatment, nothing is effective. Please don't get the wrong message. All I'm saying is, when we buy evidence, new evidence coming out and different drugs are being advocated, I think we have to be cautious in buying that evidence. That's all I'm saying. The typical example is hydroxychloroquine. Even I know people in my family who took hydroxychloroquine even against my advice, and FDA has stopped all the trials, based on Trump's assumptions. They've gone against it. So medications, I would say, only on advice of your treating clinician, even if you are a clinician yourself or a doctor yourself.
Thank you. So basically, what would be the advice for somebody? Because there's a particular reason for asking this question, is that we are fast approaching a situation in which we are almost like bracing for impact, because it's all around us here now. So anybody can be positive any day. So if you have mild symptoms, is there anything that you can start at home besides the regular paracetamol, like a simple antibiotic, or what's the evidence then?
I don't know what the antibiotic would do for this particular infection. I think you can try all the home-based remedies. Hundreds and thousands of them are being floated now on the social media. See what works for saline rinses, for example, hot saline rinses. But I honestly don't have an answer to your question. I wouldn't say any medication. I think if you have worsening symptoms, then you seek medical help. And that's all I can say. And it may be relentless high fever, anything about 103, particularly breathing difficulty. Those two would be on top of my list. You seek advice. A lot is being talked about pulse oximeters. If you have one, great. But when your oxygen saturation is going to drop below 90, you will feel it anyway. So that's your pulse oximeter there. So seek medical advice. It might alert you fractionally earlier, so it's helpful. But I think overdoing is there is so much you can overdo it.
Okay. So are the practices in the UK looking for long-term engineering solutions?
Sorry, you are asking me questions which I don't think so. There are answers. There are straightforward answers.
Sir, these questions are being asked by everyone around us.
No,
Many of them have stockpiled.
It's great to share. I'm just acknowledging my lack of knowledge and lack of expertise on these questions. That's why I'm saying it. It's good to discuss. I'll contribute as much as I can, and I'm sure people might have slightly different views on it, but I'm just acknowledging that I'm not an expert on these questions.
Okay. Are the practice
answers? Trump took hydroxychloroquine. So should we, it's the same thing.
Are the practices in the UK already looking for a long-term engineering solution to, for example, the exhausting and the filtration of air and everything?
I think it's very individual. Uh, I think if you can demonstrate that you've got up at least 6 air exchanges in per hour, and that you have means of cross ventilation, my suggestion would be not to overspend at this point. We don't know which way things are going, but I know people are spending and there are people who are not spending. I don't know. Adil, do you want to say anything? If people are doing things differently, maybe Dr. Kashif is if he's here, or Dr. Nafis. If you can unmute Dr. Adil.
Well, I think, very well summarized overall overview of this perplexing subject, which is developing by the day. I think it's highly variable, like you said. It's different in the NHS sector, different in the private sector, but there are huge variations. At the moment, it's more survival mode because practice just started 2 weeks ago. So people are just trying to start off slowly, follow the SOPs. And like you mentioned, stress and complacency are two of the biggest issues. Stress for the staff, the nurses, giving confidence to everybody to come to work. So it's highly variable. So I know some corporates, for example, who have a lot of money at their disposal, they bought every single gadget that's available and used it more as a marketing tool for patients, that we have this air filtration system and we have this and so on and so forth. Whereas other practices spent hardly anything. And just like in Pakistan, PPE has generally been hard to come by. So more they've just been trying to get their basics right. In the future, where it's going to go, everyone's guess. We don't really know.
If I could also take this opportunity, if you can share a little bit about how all procedures in orthodontics are being considered non-AGP now. If you could just talk a couple of minutes, 1 or 2 minutes on that.
Yeah, that was quite a surprise. So after spending weeks of stress and reading all the innumerable SOPs published by different bodies, sometimes changing twice a day, updated twice a day. It was all of a sudden, after 5 days of opening, that the CDO, the Chief Dental Officer, who is in charge of all the directions for dentistry in the UK. So for me, I work in specialist orthodontic practice. So we're only concerned about orthodontics. So suddenly it came to light that there was a statement just in there, which said all orthodontic procedures are considered non-AGPs, which was kind of a surprise. I mean, we had lots of SOPs in place for so-called AGPs, but they only designated 2 or 3 things that we may use in orthodontic practices, like 3-in-1 together, and using a high speed, which we don't use much, and using a sandblaster, which again is not routinely used. Otherwise, everything else was designated non-AGP, which was kind of a surprise both ways, I guess. A good surprise in that we didn't have to follow so many of the AGP protocols, but also kind of stressful because just like many of the other recommendations, you suddenly think whether it's politics and finances coming into it, governing some of the SOP. So at the moment in the UK, the majority, 90–95% of all orthodontic procedures are considered non-AGP. But of course, we're following all the same protocols. I mean, you mentioned earlier, it's a very comprehensive and well-balanced presentation. But just to add a little bit to it, our doors are locked. The patients either have to knock on the door or call up to check in. And then their temperature and history is taken, a brief history at the door, temperature at the door, hand sanitizer, but then we don't let them into the practice. And that too, only the patient. So, I mean, there's some very basic common sense SOPs that we're all following, which makes sense. But yes, for orthodontics, basically at the moment, all the procedures we're doing routinely are non-AGP.
Thanks, Dr. Adil. And I think with patients' attendance, it's a bigger issue in Pakistan where you can get up to 10 people to drop you to the airport, another 10 to the hospital. So it's a big issue in Pakistan. It's a bigger issue. And maybe when you come back from Umrah, you can have up to 200 waiting for you at the airport.
That's true. But having said that, stress affects the patients as well. So with orthodontics, you have 12, 13, 14-year-old patients coming in, and everyone is stressed because they come in wearing, you can tell, the staff, everyone is on edge at the moment. So part of the slow start is also just to develop the SOPs and build confidence for everyone.
Back to Professor Samir.
So, well, we're talking about things that can't be answered. So let me ask you about herd immunity, and because of this, and that, so.
Again, I think because there are, I mean, if 60 to 70% of the population were infected, you could potentially have herd immunity, but who wants to take that risk? In the political climate, I mean, not that I'm advocating it should be done. Nobody would take the risk. And also, I think there are so many things we don't know about this particular virus. To be honest, I mean, it has outpaced everything. On one end, we are obviously complaining about things in Pakistan, but what it has done is it's exposed the most developed countries, which seem, which claim to have the best healthcare infrastructures in the world. Nobody was ready for such a pandemic. So herd immunity, I think there is a feeling in Pakistan that that's where the government is leading them. I'm not going to go into the political side of things, but I think the bottom line is we could argue that for so many countries, even the US, even the UK, there have been, people have been criticizing the government that they are leading us to herd immunity by default with the number of cases. So I don't think so that's being advocated worldwide, that it's the right direction. But by default, the rate of infection is so high that we might see it. I don't know.
Dr. Adil, you may have seen that question. What about debonding appointment where you remove brackets and have to clean the composite? Let me unmute you.
Thank you. That's a good question. So initially, the British Orthodontic Society had published guidelines for us to use prior to the surprise statement of the CDO that I mentioned earlier. And in those guidelines for bond-ups, for debonds, what they had first of all said is first to delay them until the initial period is over. Secondly was if you had to do a debond, then you would do it leaving the adhesive in place. So you do a debond by debonding the brackets and leaving most of the composite in place, but just chipping off what you could with a composite removing plier, which most of us don't use routinely. Old school used to be about 20 years ago. So more senior colleagues, they use it. And then you would advise the patient, I've been doing that myself the first week, that, okay, if you really want your brace off, we'll take it off. We'll provide you with retainers as normal, but we'll polish off the remnants of the adhesive, say in 6 months' time or 9 months' time, when COVID is completely clear, hopefully. And anyone who consented to that, we'd go ahead with it. So it was basically
the funny thing is, COVID-19 is taking us back to, street dentistry and to all the older techniques. And it's just, there was a question about outdoor dentistry, and I don't know whether it was a serious question or not, but if anybody wants to say a few words about it.
Could I just finish on that? So the SOP now is you can do a debond, but you obviously need to follow all your PPE for non-AGP, so long as you are using a high volume aspirator, and you can use a slow speed handpiece with a tungsten carbide burr as normal. So long as there's no spray and you're not, the teeth aren't wet, but you're going to do all of that with your high volume aspirator. So that's kosher nowadays. That's non-AGP, and we can do it.
Rubber dam is being applied and then you're disinfecting the area first and then doing all of this to try and keep it as dry as possible, I suppose.
No rubber dam, not for orthodontics.
Professor Adnan Shah is here. Sir, if you have a comment.
Assalamu alaikum, everybody. Kamran, thank you very
Assalamualaikum,
much.
sir.
Thank you. And Adil is there too. I mean, for a change, I've seen him after a very long time. Assalamu alaikum, Adil. All the great students that I had, I must say. Uh, and Sarmer too, Adnan Aslam here as well. I mean, Hassan Bashir, mashallah. It's very heartening to see everybody there. Kamran, a very well articulated, a very comprehensive description of things. And I think you've made me wise today. I was going to write an email to somebody today about some of the procedures, and I found few arms to be loaded with, and I should probably be blasting off to them. Thank you very much for providing that opportunity. And I think it's for the youngsters here to benefit from you and from Adil and for Samir and everybody down here, Dan Aslam, Salman, Ashraf, to actually take those messages and actually try and communicate with you more often to get more information. A couple of things I would just like to reiterate, and I think it's important. One thing that we need to probably also address is we know that there was a dental fear in our patients. And I think this is now confounded with the COVID anxiety. And I think that needs to be alleviated. We have to stress on that part as well, and that would come with more communication, communication with the patients on your web pages, advertising, whatever that is. In a North American study, about 50 to 80% patients are now have a COVID anxiety or fear going to a dental surgery.
True.
And I think that needs to be addressed very effectively. I don't know, I'm sure that's the same in Pakistan. I can probably share a very recent example. And I had a patient at FCOM, I think probably you had left. In 2007, we did a huge ameloblastoma, did a hemimandibulectomy and with a recon plate. And I was laughing that we didn't have a VSP in those days. There was no stereolithographic modeling. We did some iliac bone grafting. She's all fine. She just contacted me after 12, 13 years. She had some TMD pain, I suppose. And so I referred her to a friend of mine in Sargodha, Dr. Arshad Mahmood, Arshad Shahid, for her to seek some advice. And I wanted him to take some pictures and he missed a few. And then I asked him to take them some more pictures. And so he contacted her and she was reluctant to go back to the dental office because her family was not comfortable sending her back again to a dental office because of the COVID. So I think that fear has to be alleviated. And I'm sure that is there with us in Canada. I'm sure that is there would be in the UK, and I'm sure people in Pakistan are also. And in fact, one of the studies that I was looking through in the pre-COVID area, 1 in 5 patients would have a dental fear, but now 1 in 5 is comfortable with the treatment. So it's been upside down. So I think that needs to be. So there's a lot of unpredictability prevailing in the society regarding COVID. So we have to tell them, we have to show them, and we have to do it. So it's tell, show, and do. So lots of communication, lots of planning, and lots of training needs to go in. And then communication amongst the staff, communication with the patients, proper screening as you alluded, and I think Adil did that. I mean, I get tested every day. I get screened every day in the morning when I go to hospital. My temperature is recorded. When I go back the same time or the same day to my private office, my girl, and as you very rightly said, those girls have the authority to check me. They actually check my temperature every time. Although they are my, I actually employ them, but they would check it. And so that's the liberty and that's the professional accountability that we all have here. Which I'm sure most officers in Pakistan would also have it, but we try and don't take it very seriously, which is a sad part. Coming back to COVID testing, very rightly said, but I think again, the chair-side testing would be a great option and probably will be a great tool to help most professionals. but I think the validation of a false negative. I was reading a study. In the first 5 days of exposure, it can go up to 67% of false negative. It drops down to about 25%, 21% at day 8. So I think there's a lot of variability there as well. And that actually highlights the importance of your PPEs, your stringent criteria of triaging these patients, screening these patients. And actually, I would, non-Islam, I would actually go and actually promote modifying our surgeries. And I think take this as an opportunity in Pakistan. I mean, we have taken this opportunity in the rest of the world too, that we are now better prepared. I mean, it's COVID 2 today. I don't know what happens tomorrow. I mean, that might be a COVID 3 or COVID 4 coming. So I think this is an opportunity for all of us to actually develop our protocols. Samer was on the forefront doing about hepatitis B and C, I think, but this is something else, but it has to be an ongoing process. So probably this has given us an opportunity to build our practices in a way which will be cost effective, which will be safe to practice. We will gain the confidence of our patients. And obviously it's going to generate revenue, which is also important. So I think some of those my thoughts that we take this as an opportunity. We have got a negative pressure in our private practice. We have got a negative pressure in the hospital clinics. Most clinics in my city are having negative pressures. But again, as I said before, my message too, that we can only advise. I mean, I can only talk of my experience, and my experience is dictated by the prevalence of COVID in my area. So any recommendations or any strategies that needs to be evolved is based on the COVID status in respective areas. And it could be Pakistan is in an absolutely different situation now. So some of my thoughts, but I think great. I think everything is important to listen. Everything is nice to hear because we all improve, and it's a long haul. I mean, we are COVID-19 is there for some time, and as I said, be very cautious. It will be a COVID 2021. Who knows? Thank you.
Thank you very much, sir. Such a pleasure to hear your voice. It's so reassuring. Somehow for your students, for us who looked up to you, just to hear your relaxed demeanor sort of puts, us at ease. So, sir, such a pleasure and honor. And I think maybe this is the only good thing that's come out of COVID-19. We get to sort of see each other or meet each other occasionally. And so such a pleasure. Thank you so much. So, ladies and gentlemen, this is an opportunity. If there are any further last questions that we want to ask Dr. Kamran or to any other members of our audience. So
just whilst you gather the questions, might not be relevant for the senior colleagues, but Hassan has provided a web link where you can provide some feedback on this session. And then obviously with, words of wisdom from Professor Adnan, Samer, Adil. So it's not just my presentation, it's the whole session. And you will be awarded 2 hours of CPD by the PDA. So endorsed by the university. Provide feedback, you get an automatically generated receipt. If you share that with Hassan and provide your PMDC number, you will get CPD certificates. And that is also an opportunity. I think the CPD certificates in Pakistan are issued randomly. There is no good format. So GDC in the UK, they've kind of developed a good format for recording CPD, and that might provide a good template for future certificates. Sorry, that's it.
Kamran, I must thank you again for taking time out for us. And I hope that, you'll again take some time out for all of us. And I hope that we all meet here again very soon. So with this, I'm going to hand over to Dr. Hassan Bashir for conclusion. Who is not here? Who is here?
Quickly, Dr. Wasim Ibrahim is with us, so he raised a hand. If sir, I have unmuted you. if you want to add something, please. So I'm trying to unmute you. Yeah, okay, sir, please go ahead.
Thank you very much. Dr. Kamran, Dr. Adil, thank you very much for the update. Naturally, many of the things which you have mentioned correctly, we are not, of course, following or are not able to follow those 100% guidelines in Pakistan because of some reason or the other. But many, or I can say most of the people in public hospitals, especially in army, they are trying to follow all these guidelines. All the normal procedures, of course, they are stopped, and only emergency dental procedures are being carried out with all precautions. And thank you very much for these nice updated guidelines. Thank you, Dr. Samir and Dr. Adnan Shah and Dr. Hassan. That's what I want to say.
Thank you.
Okay, quickly, if somebody, there are a couple of seniors, and these are the celebrities of our profession with us. I can name them like Dr. Adnan Shah, Dr. Wasim Ibrahim, Dr. Adil Manan, Dr. Amjad Ali, Dr. Bilal Sheikh, Dr. Safwana Bilal, Dr. Faisal Dodi, Dr. Sulman Ashraf, Dr. Khurram Ataullah. Sir, because of the restriction of the time, I might not able to have all of you, but quickly going to end my meeting by saying some few words, and then Dr. Aisha Imran is gonna say thanks to everybody. I would request you to have a couple of second silence for all those who has passed away because of this pandemic. A very, very, what should I say, important people, they have left us. So whatever your belief is, like I'll give you just 10-15 seconds to say prayer for them, whatever you way you can. I mean, so quickly, so coming back to Dr. Kamran, there are just two words for you that you are pride of our profession, and people love you. You are lucky. Still, like there are many people who talk about you, who love you. So this is a rare trait. Like
I have
usually,
to take this opportunity to interrupt you, Hassan, and say, you know, the real test of a teacher are their students. And whenever I meet your students, Kamran, oh my God, they swear by you, and you know, they're so fond of you. So there's no higher compliment. Thank you.
Yeah, you can just enjoy this thing. Like there are hundreds, thousands of people who love you. Like this is something which is a very rare trait to find. Quickly, I'd like to add that this pandemic has exposed original of ourselves. I have seen people who was like very shy. They come up with very great ideas, like Dr. Salman Ashraf, Dr. Rashid. They are the guys, like I never knew them. Dr. Samir is like Dr. Adnan Aslam is one of those like people like I was like, I believe like it's been years we haven't talked. And they came up and they just say that, just say a word what we can do for our other colleagues. So in this raw PDF, Gujranwala is offering like if you guys need somebody to talk to, we are always here. Please feel free to call me, my colleagues, like a couple of them sitting over here, the cabinet, my cabinet, and all these seniors. I have requested a couple of them to just say a few words and send messages. I'm really grateful for whoever did that. That this is a very difficult time. the people have financial issues, the people have, there are a couple of other things, but like your word means a lot for them. So I would like to again say that Dr. Kamran, Dr. Samir, Dr. Adnan, and the many others which I have mentioned earlier. Sir, I would like to have request that kindly do spare some time, and just this kind of meetings means a lot. There are frustrations with the general dentist who is like, unfortunately could not express them, but these questions, these meetings helps a lot to them.
So if I
So
could just interject, Dr. Hassan, thank you so much.
sir,
I think we have the benefit of technology now. Not everybody has to travel, and I think you've got wonderful teachers and clinicians in Pakistan, again at the cost of repetition, Professor Samir and Professor Abid Ashar, and excellent clinicians like Dr. Bilal, uh, uh, and dedicated people. I must also thank Dr. Adnan Aslam. I know he asked me to do something like this few weeks back, and I wasn't very helpful at that point because we were having assessments. So Dr. Adnan, partly, I had that in my mind, and when I knew you were on board as well, so that was a further encouragement for me to come here. I think we've got, excellent expertise in Pakistan, and we've got people like Professor Adnan abroad, and we should benefit. And I think this platform from PDA Gujranwala, it's a small part of the country, but hats off to you. You've taken the lead, and you should stay in lead now. You deserve to stay in lead now. So I think this is the platform we can all come together and take things forward beyond COVID. Thank you so much.
welcome, sir. Quickly, Dr. Aisha, I would like to, she's our Vice President for PDA. I would like her to thank everybody. And before closing my comment, Dr. Samir, Dr. Adnan, and Dr. Rashid, like they are co-hosts with me. So I'm just bending my knees in a respect for you, because you are always here for PDA Gujranwala, and we are in debt like for your services. Dr. Aisha, if you can listen, that can kindly close this now.
Ji, Assalamu alaikum. I'm Dr. Aisha Imran from PDA Gujranwala. And on behalf of our cabinet, we'd be honored to have such a brilliant audience from pretty much all over the world. Especially in these difficult times, it's wonderful to see all the dentist professionals come together to support each other as a fraternity, to support each other, guide each other, share whatever knowledge we have to combat the problems in these unfortunate circumstances. So on behalf of PDA Gujranwala, I want to thank Dr. Kamran Ali for sharing his knowledge and his experience with us. We've had some really amazing input from Dr. Adil Manan and Dr. Adnan Shah, sir. Thank you so much for being here and for your words. You just took me back to the lecture theater back in De Montmorency. It was wonderful to hear from you again, sir. We are really honored, and most importantly, I would like to thank the participants on behalf of PDA Gujranwala for making this such a wonderful and successful meeting. The hosts and the co-hosts of this meeting, Dr. Hassan Bashir, Dr. Samir Qazi, Dr. Adnan Aslam, Dr. Rashid Mahmood, and Dr. Naseem Mansha from our team. He is also here. Dr. Rizwan Asghar is also here. Salman Manyar Sahab, and thanks to Dental Health newspaper. So thank you for everybody in making this meeting such a success. Over to you, Dr. Hassan.
Okay, thank you, sir. Just a last one-liner, if Dr. Kamran want to add something, then we.
No, I think everything has been said. I'm really grateful to Professor Adnan. It's a great honor to have him on the session. Honestly, I didn't want to bother him to invite him, but I'm so pleased he's here. That's an absolute honor. Professor Samir, we had some very interesting times in Pakistan together, some very good moments. So it's an opportunity to just recall those, and hopefully we can get together on Zoom, some of us, and relive those moments. And maybe Hassan, you can invite Professor Adnan, Adil, Samir, and so many others on a separate lecture type setting.
So we love to. We love to.
I was the happiest person when Hassan asked me to facilitate this meeting, because I was reminded of all those times. Yeah, so really nice. Thank you very much, everyone.
And one last thing, I praised Rashid's videos, and then you provided very appropriate feedback, very appropriately highlighted the shortcomings. And honestly, I'll be honest, I mean, I didn't watch all the videos, but the reason why I appreciated them so much was it takes a lot of courage to put yourself on the spot and say, this is how I'm doing it. It takes so much courage. So that was something which stood out for me. And that's the culture changing in Pakistan, as Professor Adnan has said. You're going to take it forward. And those are some of the really encouraging things beyond, anything else, that people are prepared to come forward and share their knowledge. And I'm sure Dr. Adnan would know what I'm referring to, but back in the days, we would have people who would say, I know this thing for 30 years and nobody knows. And they would take pride in that. I mean, come on. So knowledge is about sharing. You're not going to add anything by holding it close to your chest. So that's where I'll stop. I'll stop now. I'll actually stop. Thank you.
Thank you. See you guys, all of you, again soon, hopefully in a good health and in a high spirits. Allah Hafiz.
आपने जरूर ऑर्गेनाइज करना है एक Zoom session, Professor Adnan, Samir, Professor Abid Ashar.
Sir, done. Sir, consider it done, sir.
Non-lecture, Adnan Aslam. I mean, I'm not saying others can't come, but we'll just relive some of the moments.
So we'll do that. We'll do that.
I think we need to get back to our deep Bonbarancy days.
Yes, absolutely. Absolutely.
Sir,
Thank you very
sir.
much, everybody. MashaAllah, very nice. Khuda Hafiz.
Allah Hafiz.